My question is to Dr. DeGutis. You mentioned the 20 core state
Right.
programs that are out there. I wonder if you could speak in terms of what actually you mean by core.
Sure.
What are some examples of what that work looks like in a state? And thirdly, how do we move to have all states, tribes, and territories have a core program?
First of all, we would like to see every state, territory, and DC have a program that addresses injury in their health department, much as they have programs that address chronic diseases or infectious disease, simply because the burden is there, and it's, as we pointed out, it's worse for younger people and everything. The core programs, basically what the funding, that funding provides, it's about $250,000 now a year, or in this next cycle, and the state is allowed to do what they think is important in injury with that money. They often leverage it and get other funds to help do injury prevention work. They will collect data at the state level to find out what the problem is, to find out what kind of impact that they're having on, on injuries in the state. They may pull together in this past round of funding, we've had the community injury prevention planning groups that have been representative of various organizations and agencies within the state to work with the state health departments to identify significant problems and interventions that could be done at various levels in the state, whether it's statewide intervention or something that might be a local community intervention. So some of the things the core program might do would be bringing together a group, creating those collaborative initiatives. They would be doing the data collection. They would do some evaluation. In this funding that we have now, we've also funded 5 regional network leaders, and those are states that are funded to help both the states that have the core funding, but also the states in their region that don't have any funding for their programs, so that they can provide technical assistance, they can help them to do things around injury prevention in their states, and hopefully develop a program and apply for funding when there is another opportunity. There are also some supplemental funding streams that are going to some of the states, and they had to competitively apply for these. It was in motor vehicle injury prevention, falls prevention in the elderly, in quality improvement and surveillance to improve their data. So those were areas that they could compete for, and we've funded some of the states to really focus on those areas and provide really model programs and examples of what can be done at the state level to create that kind of program. So that's where we are. We're hoping to get more funding that we can get to the other states. We're still working on it. We constantly work on it. And we also know that I think Dr. Frieden has been very supportive of trying to find other ways to get money to the states too. So.
My question is for Dr. DeGutis, that I think we all agree that this kind of work is terrific and much needed, but it's very hard to kind of figure out what the right priority level is when we all have so many competing demands. It's also very difficult to get funding for that kind of work. And so I'm wondering if you can kind of speak to that conundrum.
Some of the things that we're trying to do, and we're hoping that the regional network leaders will also be able to help with this, is to work with some of the states to help them understand how to use their data to change some of the policies, to understand what the model policies might be in specific areas, to look at states that have done well in various areas. And then I think we have a number of initiatives even emanating from the center where we're providing technical assistance to states on some of the data usages and how they can translate data. Some of that is happening with primary seatbelt laws, with GDL laws, with alcohol interlock devices, so that states can get information from us. The other thing that we've worked on that is also, I think, helpful to the states are some of the policy impact briefs on various areas. So we have some, again, in motor vehicles, we have quite a number of them. We have some on motorcycle helmets, and those are really useful tools for states. So I think it's costly, it's hard to find the funding to do it, but it's really important, and the impact that you can have by doing it is really, I think, significant. So the regional network leaders, I think, are going to be very important in some of this.
And I think that the big gap here that nobody's really addressed today is also what happens to the local health departments and the local health systems.
Yeah.
And so, I mean, what I'm excited about with the work that Hopkins has done in the State House is that they come from local areas. And so we have situations where, basically say the work of public health is done at the local level. I mean, the policies are federal and state policies, but ultimately, when it comes down to delivering the programs, it usually happens at the local level. And I would hazard a guess to say that the majority of local health departments in this country have no infrastructure whatsoever to do injury prevention. And we've got to fix it.
Well, I think actually based on what we heard from the recent NATO meeting, which was just last week, it's close to half of local health departments who were represented there, who were part of a discussion there, were actually doing work in injury. And so there is some strong interest in it. A lot of them are doing work with child safety states, with a lot of it's really related to children. And a number of them are also doing work with the elderly in falls prevention. But I think the other piece too is linking the state and local health departments and looking at how they can work together and really strengthen some of those initiatives. So if we have funding that goes to the state health department, how do they help leverage that so that they can do things with the local health departments? How can they help create some either uniformity in policy that runs across the state? How can they work? How can they work with their local health departments?
And I think this is something where we really need to strengthen the data on this,
Yeah.
because I think a lot of people say, well, we're working on it. But in the case of my county, which had close to 800,000 people, we had $3,000 from the state. And when we added the little bit of money that came from public health nursing, we realized we had 4.7 cents per citizen per year. So we can say that we're working on injury prevention, but what does 4.7 cents per citizen per year really buy you? Having said that, I think we got some amazing stuff done just through partnership and collaboration.
I was
And
gonna
so
say. And when we're saying
yeah.
public health,
Yeah.
let's not forget the emergency services. As somebody who's spent a lot of time doing this kind of injury stuff through fire departments, they're struggling too. And the people often who are doing the prevention and education work are typically the first to go. So it's kind of like, we all have to link together, because otherwise our efforts will be dispersed and we won't make an impact.
Sort of a more broad, generic question for both of you. What does the Prevention Trust Fund dollars mean to you and the job that you do? And the second part of that is, what does it mean to you if it's taken away from you?
Okay. For us, certainly, it means that we can really expand our efforts and provide more support to states and local areas in moving forward on prevention activities and helping them to implement programs in their states. I mean, I think that's one of the critical pieces. We will be able to take some of the work that's been done and some of the interventions that have been demonstrated to be effective and translate them and move them into the community so that we can decrease the number of deaths and injuries and long-term disabilities that occur. If that money doesn't come through, what does it mean for us? It means fewer states that are supported, fewer local health departments that can do things, so fewer interventions that can actually be disseminated, and actually a lack of moving what we know are successful interventions and successful policies to a level where they can be implemented and used to prevent injury. And I think to some extent we need to look at this as actually even a moral and ethical issue. If we know something works and we're not doing it, then we're accountable for not doing it or not providing the resources for making that happen. So I think we really need to look at it that way.
Carolyn, did you want to say?
Yeah, and I think that many states managed to piece together pieces of funding to build their capacity. And I think one of the challenges that we see every time the funding is threatened is that people walk. Being able to hire people with training, being able to retain people with training is critical to our ability to do anything. And so anything that helps us have some sustained input into the health department allows us to begin to really not just build capacity but hone it. Every time we lose somebody, we lose that network of relationships that's being developed in the state. It's a real problem for us. I mean, one of the reasons that the county that I worked in, I worked contractually for many years between academia and practice. And one of the things that happened with the public health cuts was the county executive had made a commitment to no layoffs. And so basically every discretionary contract was just gone. And despite the fact that people close to the executives said that's the most expensive $60,000 you ever saved the county, The fact is that these are decisions that people who don't have that buffer funding have to make in order not to lay off people who that they're contractually otherwise bound to, so.
I think the number you gave, Linda, was 30% of those dollars are going to injury prevention activities. There are some states that's the only funding they have for injury prevention, and that program will be wiped out completely. And they probably don't have the infrastructure in place to even write for a grant should Dr. DeGudis' center get more resources. So it's sort of this snowballing effect of cutting money here or there and the other place, that they end up with nothing, not to mention the education. When Carolyn talks about people being laid off, so you've done on-the-job training, those people are out of a job, you lose that core knowledge for continuing the program on, you start from scratch again. So it's really not a good revolving door.
If I can reinforce, in terms of the impact that we're seeing at the state and local with 43,000 positions and jobs lost, again, to the point, we don't have the people to do the work, let alone then to even write for the application. So we are unfortunately in this perfect storm, to the gentleman's point. We need those funds for the public health trust fund, but also for the prevention fund, which is almost a third now of work in injury and supporting EMS in states.
The other issue is that we sell problems and not solutions. I mean, we know there are solutions, but think about it. What we're saying injury prevention. It's always about avoiding the negative, remembering that you're vulnerable, remembering that you could die, as opposed to selling injury prevention as something that builds futures, preserves potential, liberates people to do what they're meant to do. And I think if people don't have to face the reality of injury prevention, they won't. And I think we just have to get much better at selling the solutions and not selling the problem all the time.